Well, my practice is a general ophthalmology practice, but for the last 24 years I've also specialized in medical retina. We're between Portland and San Francisco, so we're a long ways away from university centers. So cataract surgery, I've done about 11,000 in the last 24 years. Medical retina was primarily treating diabetic retinopathy until recently, and for the last 3 years we treat wet macular degeneration with Avast and dexamethasone injections, and we do 3 or 4 injections a day typically for wet macular degeneration or other causes of macular edema. Glaucoma has accumulated in my practice over the years, and it's we see glaucoma patients every 6 months typically, and we do 12 to 14 glaucoma follow-ups a day. SLT procedures, I've had the SLT for the last 8 years. We've done about 2,500 total procedures, and iridotomies are much less common, probably do 4 or 5 iridotomies a month maximum. And capsulotomies, going along with the cataract surgery, used to be close to 50%, and now they're closer to 10% with the Acrosoft lenses not needing capsulotomies as often. The main change in my practice is to recommend and have most patients accept SLT as primary therapy. I was never comfortable with the long-term safety or efficacy of ALT, and once I changed the parameters and started getting really good results with the SLT, and one procedure at a time, we figured out this is not a dangerous intervention. It became my primary therapy. Well, managing eye drops is as everyone out there knows, there's problems rarely with medical side effects and commonly with ocular surface side effects, compliance issues, cost issues becoming more and more significant. And to offer a single procedure that costs less than a few months of eye drops and have it work and not cause trouble has been it's just a godsend. And I have to repeat, I can't imagine, given that SLT is available, I can't imagine having a large glaucoma practice without having access to that procedure. We've had the SLT, as I said, 8 years, and we quickly evolved into offering it as primary therapy. And so patients who've never been treated with anything, and we've decided that their glaucoma concerns are such that we need to lower the intraocular pressure, I recommend SLT as primary therapy. And that's an interesting, there's an interesting contrast between people who do this. I know Dr. Rhee at Harvard has often debated that SLT is an appropriate primary therapy, and he offers laser, SLT laser or drops to all of his patients at that point where they've decided to lower the intraocular pressure. And he admits behind the scenes that about 98% choose drops. Well, it may be in how the recommendation is made, because I offer SLT as primary therapy to all patients, and well over 98% choose SLT. We also use it for patients who have already been on therapy to lower their drops, or more importantly, people who are on drops and the pressure control is not adequate. We offer SLT in addition to glaucoma drops. Initially, when my unit was installed 8 years ago, Luminous gave us appropriately very conservative parameters for doing the procedure and recommended 180-degree treatment at that time, and barely threshold or even sub-threshold treatment in terms of champagne drops, champagne bubbles. I evolved over the period of about a year, not particularly happy with the results with these very light treatments, and I discussed this with George Alvarado and with Mark Latina and others, and we all at that time evolved to 360-degree treatment and using more power, where it's clearly super threshold treatment and champagne bubbles appearing with most shots, if not all. And at that point, the results became very good. And we have done a database analysis of all of our results. And basically, patients who've never been on eye drops, if you define success with SLT as a 20% pressure reduction, and we're pretty rigid about that. If it's 19%, if the pressure goes down 19%, it's a failure. If it goes down 20%, it's a success. Defining it that way, the SLT procedure in patients who've never been on eye drops is 75%. And those who are on one eye drop, it's 75%. The mean reduction in pressure in patients who've never been on drops for the whole group, including the failures, is 34% in our study, except for those people with narrow angles that got laser iridotomies, and that group had far and away the best pressure reduction. The pressure reduction of the combined iridotomy followed by SLT is 44%, not 34%. And they represent our the group with the best response to laser. Now, the most important group, if you will, is people on maximum medical therapy who are losing visual field, and these people are facing a trabeculectomy. The success rate, defined as 20% further reduction in pressure, leaving them on all their drops, is not 75%. 48% of those patients, in 48% of those patients, we are able to lower the pressure 20% or more. The average pressure lowering was only about 28%, but it's an important group because they were facing a trabeculectomy, and if we can get the pressure low enough that half of them don't need that intervention, we've done the patient a tremendous favor. Far and away, the thing I like the most about the SLT is that it works. The benefits of the SLT, I mean, I can hardly imagine practicing ophthalmology with the number of glaucoma patients I have without the SLT, because once a decision has been made to lower the eye pressure, you know, the alternatives are clearly eye drops or SLT laser or ALT laser, which in my hands did not have as good a results as the SLT. And to have a single treatment that does not do harm and have significant pressure reductions. We have a handful of patients whose pressures have gone down between 60 and 70%. And that's certainly not everybody, but a young patient with very high pressure has never been treated. If you can get the pressure out of the 30s and into the teens, it's a much less worrisome situation. In addition to working very well, we have followed the long-term results of these people, and the people who have good successes, the pressures have not gone up yet. So I actually don't know how many years this laser works. We have had the procedure wear off in a small number of patients, but the tremendous bulk of the patients with a good response, the pressure stays down over a very long time. Well, Luminous has been very valuable. They also, the 2 times we've needed service, you know, we're at the end of the line when it comes to airlines, and they got people out here in a hurry who knew exactly what they were doing, and at very reasonable rates were able to make the laser work again. And two visits in 8 years is pretty remarkable reliability. As I had a professor type that I offered SLT as primary treatment for his glaucoma, and he was very reluctant, unlike most patients. And I contacted Luminous, and they got me a bibliography of published studies that he could look up and put his mind at ease. And they've been very responsive in terms of helping me with patient information, brochures, service, advice. It's just been a good relationship working with them. Well, no obstacle, obviously, no obstacle prevented me from buying an SLT laser. At the time, you know, it was a laser, and in addition to that, a U.S. patent. So it was more expensive than our retinal lasers and our YAG lasers and the other lasers that we have. But I did the math and was very interested in the technology and bought the laser. We have done an economic analysis of the decision. And in spite of the fact that it was more expensive than other lasers, it did make sense, and it's not just been okay economically for the practice, but it's been part of its quality of life of the doctor and staff. We're managing a lot fewer patients on eye drops. To a friend or any other, any colleague ophthalmologist, I know that they have the same problems that we have with managing patients on eye drops and not knowing if they're getting them in their eyes regularly, etc. So this is probably, in terms of compliance and side effects, the easiest way to lower the pressure in the 75% of patients that it works in. And I repeat, I would not care to manage glaucoma without this procedure available. I've actually talked to a number of people in that situation, and their concerns are usually related to, does it work? And I don't think, I now feel that done properly, it really works in the majority of patients.